The remaining conditions either increase the workload of the heart or directly damage the myocardium, but I wanted to go over the top 4. Now that we understand how heart failure develops, let's talk about what we actually see in our patients. So one of the easiest ways to remember the clinical manifestations of heart failure is to ask yourself 2 questions. Is the blood backing up somewhere, or is the blood not moving forward well enough? Almost every sign and symptom can be explained by one of those 2 problems. So let's start with left-sided heart failure. Remember, the left ventricle pumps blood out to the body. When it begins to fail, blood can't move forward efficiently, so it's going to back up into the pulmonary circulation. That means that the lungs are going to become congested with fluid, and it makes it difficult for oxygen to move into the bloodstream. That's why the symptoms of left-sided heart failure primarily involve breathing. So the most common symptom is dyspnea, or shortness of breath, and patients usually notice it first during activity because exercise increases the body's oxygen demand. And as heart failure progresses, they may become short of breath even at rest. So asking yourself why this happens, it's because that fluid is accumulating within the lungs, making gas exchange more difficult. Next is orthopnea. This is shortness of breath that occurs when lying flat. Now, why does this happen? So when someone lies down, gravity is no longer keeping fluid in the lower extremities. So more blood returns to the heart, which increases venous return. And the weakened left ventricle can't handle that extra volume, so pulmonary congestion worsens. And patients will often say, I sleep with 3 pillows, or I have to sleep in a recliner. And sometimes those statements should immediately make you think about heart failure. There might be other reasons, but one of the most common things we hear with patients who have heart failure. Closely related to some of these symptoms is paroxysmal nocturnal dyspnea, or PND. So patients wake up suddenly a few hours after falling asleep, feeling like they're suffocating. Again, the reason is the fluid redistribution into the central circulation while they're lying down. Many patients will describe sitting on the side of the bed or standing near an open window because they feel like they can't catch their breath. And the most severe form of pulmonary congestion is pulmonary edema, where fluid actually fills the alveoli, which significantly impairs gas exchange. So assessment findings might include crackles or rales, severe dyspnea, tachypnea, hypoxemia, and in severe cases, patients may produce pink, frothy sputum, and this is a medical emergency. So now let's move on to right-sided heart failure. So instead of blood backing up into the lungs, blood backs up into the systemic venous circulation. So the easiest way to remember this is right-sided heart failure equals rest of the body. So because blood can't return efficiently to the heart, fluid is going to accumulate in tissues and organs. So we'll see things like peripheral edema, which is the most obvious finding we see. You'll often see swelling in the feet, ankles, lower legs, because gravity causes fluid to collect in dependent areas. And when assessing edema, we want to document whether it's pitting and how severe it is. We might also see jugular venous distension, where blood backs up into the jugular veins. Remember, when we're assessing our patients, they would be sitting at a 30 to 45 degree angle to see jugular venous distension. JVD, jugular venous distension, this is an important sign of increased central venous pressure and right-sided heart failure. That congestion is also going to affect the liver, and we call that hepatomegaly. So the liver enlarges because blood pools within it, and patients may complain of right upper quadrant discomfort or tenderness, and long-standing congestion can eventually impair liver function, and we can see liver failure. Ascites, so as fluid continues to accumulate, it may collect within the abdominal cavity, which causes ascites, and patients will often describe abdominal fullness, bloating, early satiety, or increased abdominal girth. So far we've talked about congestion, and I want us to discuss a little bit about what happens because the heart isn't pumping enough blood forward. So when cardiac output decreases, organs simply don't receive enough oxygen and nutrients. So patients will often report fatigue and weakness as the earliest symptoms in both left and right-sided heart failure. The muscles aren't going to be receiving adequate oxygen during activity, so patients are going to tire easily and gradually lose exercise tolerance. We might also see things like altered mental status. So the brain is very sensitive to any decreased perfusion. So older adults may become confused. They may have difficulty concentrating or experience subtle cognitive changes before obvious respiratory symptoms develop. And cool, pale skin. So the skin becomes cool and pale because blood is preferentially directed towards vital organs. And you'll often notice delayed capillary refill and weak peripheral pulses. Another thing you might see is decreased urine output. So the kidneys are going to receive less blood flow, and as a result of this, urine output is going to decrease. So ironically, this poor renal perfusion activates the renin-angiotensin-aldosterone system, which causes the kidneys to retain even more sodium and water, which is going to, of course, worsen congestion. So one thing to remember after going over this slide here is that patients rarely present with every symptom on the slide. Early heart failure may only cause mild shortness of breath with activity, but as the disease progresses, we'll see additional symptoms develop. And eventually, many patients develop both left and right-sided heart failure. So you'll often see pulmonary congestion and peripheral edema occurring together. So now that we've discussed the different types of heart failure, let's look at how we describe how severe a patient's heart failure is. So we have the New York Heart Association, or NYHA, functional classification, and this is one of the most commonly used tools in clinical practice. So unlike left versus right-sided heart failure, or heart failure with reduced ejection fraction versus heart failure with preserved ejection fraction, the NYHA classification, it doesn't describe the underlying problem with the heart. Instead, it focuses on how much the patient's symptoms limit their daily life. So we want to think of it as a scale that answers one simple question: what can this patient comfortably do? So class 1, patients have heart failure, but they're able to perform their normal activities without symptoms. Class 2, patients are comfortable at rest, but everyday activities like climbing stairs or carrying groceries cause shortness of breath or fatigue. Class 3, patients have a marked limitation. Even activities such as getting dressed, showering, or walking across the room can trigger symptoms. And class 4 is the most severe. These patients often experience symptoms even while resting and may become short of breath during conversation or while sitting in a chair. So as nurses, you'll often see the NYHA class documented in the patient's chart because this is going to help communicate disease severity, evaluate response to treatment, and determine whether patients may need more advanced therapies. So a patient's NYHA class can improve with effective treatment, or it can also worsen as heart failure progresses. So this may change over time. All right, so far we've talked about where heart failure occurs, left versus right, and how severe it is using the NYHA classification. So let's now talk about another way heart failure is categorized. And this is going to be by how the left ventricle functions. So there's two major types. We have heart failure with reduced ejection fraction, and we have heart failure with preserved ejection fraction. And although these patients look very similar clinically, the problem inside the ventricle is going to be different. So let's start with heart failure with a reduced ejection fraction. And the easiest way to think about this is that the ventricle is weak. So the heart muscle has been damaged. It can no longer contract effectively. And because it can't squeeze well, less blood leaves the ventricle with each heartbeat. And this is called systolic dysfunction because the problem occurs during contraction. So the most common causes are conditions that damage the myocardium, including previous MI, coronary artery disease, dilated cardiomyopathy, chronic volume overload. And so as the ventricle weakens, it often becomes enlarged and dilated. So what is ejection fraction? So ejection fraction tells us what percentage of the blood inside the left ventricle is pumped out with each beat. And normally the left ventricle ejects about 50 to 70% of the blood it contains. So in heart failure with reduced ejection fraction, the ejection fraction is 40% or less, meaning the ventricle isn't pumping effectively. Now, the good news is that we have several medications proven to improve survival in patients with heart failure with a reduced ejection fraction. And these are those ACE inhibitors, beta blockers, those mineralocorticoid receptor antagonists, and those SGLT2 inhibitors. So these medications don't just improve symptoms, they actually slow the disease progression and reduce mortality. So now let's compare that with heart failure with preserved ejection fraction. So instead of a weak ventricle, we now have a stiff ventricle. So the ventricle contracts normally, but it doesn't relax very well during diastole. And because it's stiff, it can't fill with the adequate amount of blood before the next contraction. This is called diastolic dysfunction. So some of the most common causes associated with this condition, which make the ventricle thick and stiff, include chronic hypertension, aging, obesity, diabetes. So unlike heart failure with a reduced ejection fraction, these patients often have a normal-sized or a thickened ventricle rather than a dilated one. So why is the ejection fraction preserved? So this is a concept that confuses people. So imagine you have a small cup that only holds 50 milliliters of blood. So if the heart pumps out 60% of that blood, the ejection fraction is normal. But 60% of 50 milliliters, that's only 30 milliliters. Now compare that with a healthy ventricle that it's filled with 100 milliliters and it ejects 60%. That patient pumps out 60 milliliters. So even though the percentages are identical, the patient with heart failure with preserved ejection fraction pumps out much less blood overall because the ventricle never filled adequately to begin with, if that makes sense. So that's why these patients still develop symptoms of heart failure despite having a normal ejection fraction. Let's talk a little bit about treatment. So treatment for heart failure with preserved ejection fraction is going to focus on managing the conditions that cause the stiff ventricle to begin with. So this includes controlling blood pressure, managing diabetes, treating obesity, maybe they have sleep apnea. So using diuretics to help relieve congestion. And unlike heart failure with reduced ejection fraction, fewer medications have consistently been shown to improve survival, although SGLT2 inhibitors have demonstrated benefit in reducing heart failure hospitalizations and improving outcomes. So now we've discussed what heart failure is, how it presents clinically. Let's talk about how we confirm the diagnosis. So one thing I want you to remember is that there is no single test that helps us diagnose heart failure. Instead, like many disease processes, we're going to combine the patient's history, physical exam, lab findings, imaging, and cardiac testing. And that's going to help us build a clinical picture. So everything is going to begin with the patient's history and physical assessment. And this is one of our biggest rules. We're going to ask our patients, are they short of breath? Are they sleeping on multiple pillows? Have they gained weight recently? Are they more fatigued than usual? Have they noticed any swelling in their legs? And during our assessment, we may find things like crackles in the lungs, JVD, peripheral edema, maybe an extra heart sound, an S3 gallop, a displaced point of maximal impulse, which could suggest ventricular enlargement. So these findings are going to help us suspect heart failure. Next, we're going to do some lab studies, and one of the most important is BNP, or B-type natriuretic peptide, and its related marker NT-proBNP, which is a little bit more specific. So when the ventricles become stretched from increased pressure or volume, they release these hormones, and higher levels make heart failure more likely. However, BNP should never be interpreted by itself. So, for example, levels may also be elevated in older adults, chronic kidney disease, pulmonary hypertension, sometimes acute illnesses such as sepsis, and that's why we always interpret BNP alongside the patient's symptoms and physical exam. Other lab studies include electrolytes, because many heart failure medications affect sodium and potassium. BUN and creatinine to assess that kidney function before and also during diuretic therapy if that is what the provider would like them to be started on. Thyroid studies, because thyroid disorders can also contribute to heart failure or dysrhythmias. CBC to evaluate for anemia or infection, both of which can worsen symptoms. We might also grab electrocardiogram, so an ECG. It usually doesn't diagnose heart failure directly. Instead, it helps us identify possible causes. For example, we may see evidence of a previous myocardial infarction. We might see atrial fibrillation, left ventricular hypertrophy, some conduction abnormalities such as a bundle branch block. So remember, the ECG helps explain why the patient may have developed heart failure. Also, we can get a chest x-ray, which could help us evaluate both the heart and lungs. It may show cardiomegaly, meaning an enlarged heart, pulmonary vascular congestion, pulmonary edema, maybe some pleural effusions. And one question is, why are we looking at the lungs if we're talking about a heart problem? Remember, left-sided heart failure causes blood to back up into that pulmonary circulation, which creates congestion that becomes visible on chest x-ray. So that's why. We could also get an echocardiogram, and this is considered the gold standard imaging test for heart failure because it tells us both how the heart looks and how it functions. An echocardiogram allows us to evaluate left ventricular ejection fraction. We can look at the chamber size, valve function, wall motion abnormalities. We can look at the diastolic function. We could also see pulmonary artery pressures. So this is the test that helps us distinguish that heart failure with a reduced ejection fraction from heart failure with preserved ejection fraction. So it makes it one of the most important studies for guiding our treatment. Other tests, so depending on the patient's presentation, we might see additional testing. So a stress test, which evaluates for myocardial ischemia, maybe cardiac catheterization, which can allow us to directly visualize the coronary arteries. We can also measure intracardiac pressures using a cardiac catheterization. Cardiac MRI, this can help identify cardiomyopathies or infiltrative diseases such as amyloidosis. The 6-minute walk test, this is often used to evaluate functional capacity and monitor disease progression over time. A little bit more about BNP interpretation. So you don't need to memorize every number for NCLEX. On the slide, you'll see on the lower right side, but you should understand the concept. Like generally speaking, if we see a low BNP, this is going to make heart failure very much less likely. A very high BNP, this makes heart failure much more likely. And intermediate values, they're going to require a little bit more interpretation in the context of the patient's symptoms and the physical exam. So we want to think about the BNP as another piece of the puzzle. It's not the entire puzzle though. And so that is it for today. I will see you in class, and we will talk more about the management, the medications, our role as nurses, and how we're going to manage and care for our patients with heart failure. So I will see you then. Have a great day.